have 13 attendees, which is great. Katrina is going to record this webinar for us, which is wonderful, so that we will be able to post it online, and anyone who's not able to attend can take a look at it. We will also, we've actually already put the presentation that we're going to go through on the NPKUA website. So hopefully we can encourage people to take a listen and look through the slides if they're not able to attend tonight. So again, this is Kristen Bonix, and I'm so happy that you all joined us this evening. We're going to go through a bunch of different things, give you all some different updates. Hopefully we can get through the presentation portion in about, I would say, hopefully about 20-25 minutes, and that way we will have a lot of time for questions and getting down into the details. We also have, Amy Oliver on the phone and Christine Brown, who of course we all work very closely together on all the different things that we try to put together for advocacy, so they can chime in also if I forget something, and we'll be here to also answer your questions. I was going to ask everybody to mute your phones, but it sounds like there's not too much background noise. You can, I mean, if you have a question, we don't have, well, I guess we have 17 people now, so it's starting to get higher in the numbers. So if you have a question while I'm going through the presentation, you can either just hold on to it, make a note, or you can put it in the little chat box on the webinar, and we'll make sure that we go through those questions in the chat. If you don't want to forget about it, you can stick it in there. So let's get started. So what we're going to cover is what happened with the National Defense Authorization Act that many of you, I'm sure, probably heard of. The Medical Nutrition Equity Act, which is our draft bill, we're going to talk about the status of that legislation. We'll talk about what can be done at the state level, different options for individuals out there who want to get involved in advocacy and do something at the state level, and we're going to talk about some best practices for advocacy. We'll also discuss our priorities, or our sort of draft priorities for 2017, as well as the lobby days that we will have in DC in May. So lots of exciting things happening, lots of good things. So let's see if I can get to my next slide. That would be good. Okay, here we go. So the National Defense Authorization Act. So this is the annual bill that funds our Department of Defense. And there was an opportunity identified for this where we could affect TRICARE insurance. This came about, we were working on the Medical Nutrition Equity Act, which aims at addressing coverage for everyone in all different types of, all private and public plans. And in an organization we have been working with, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, realized that there was an opportunity to take that draft legislation we've been working on and put a piece of it into this annual budget bill to improve TRICARE coverage. And so that happened, and we sent out several different action alerts and over the last 9 months or so. Before this passed, or currently, we have had formula coverage, PKU formula coverage in TRICARE. I know there have been people that have had issues with it, but technically TRICARE is supposed to cover formula today. So this legislation, medically necessary foods legislation did pass in the final bill, which is super, super exciting, because this is the first time that any federal legislation has mandated coverage of medical food. So that's a big, big win in terms of what we've been trying to accomplish. And it was a pretty neat thing because we worked with a lot of different, several different organizations, different advocacy groups to get it done. So definitely showed that, when we work together, we can accomplish a lot. So one thing that's really important is that it extended our coverage of medical foods to the low-protein foods. So that will be included in coverage. I did see a lot of questions on social media about, well, when is this going to go into effect? I did do a little bit of research, and because it's really kind of hard to tell when exactly, what exact date, but my understanding is that it would be probably, at least a year after the bill was enacted. And so the bill was enacted in, I think, the December 23rd of 2016. So likely we would not see the changes for the low-protein foods go into effect until, the end of this year or the beginning of 2018. But it's going to happen, so that's super exciting. So the big bullet here for me, I think, is the coverage will set an important precedent for other federal programs. It's something where we can build on this, and it's super exciting. So thanks to everyone for speaking up for PKU, because I know many of you that are on the phone, if not all of you, played a role in making this happen. So really, 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 we appreciate it. My computer doesn't want to go to the next slide here, so 1 second. Okay, here we go. So the Medical Nutrition Equity Act, this is the new bill, like the Medical Foods Equity Acts that we have proposed and had introduced in Congress in the past. It does include coverage for some other conditions beyond the newborn screening metabolic disorders, so several GI conditions and some absorption disorders and that type of thing. We've been working closely with 2 other organizations on this bill with Senator Casey's office. Senator Casey is the lead sponsor. The gastroenterology organization, NAFIGAN, that I mentioned before, that played a big role in getting the TRICARE coverage through, has been playing a very, very big role in terms of coordinating some of our advocacy efforts and coordinating with a lot of different organizations that are interested in this type of legislation. So that bill is still in draft. I mean, and the big thing for us, and we've been working on it for, it feels like a year or more, is finding a Republican co-sponsor. And that's really important. Senator Casey, bills are a lot more successful usually when you have a Republican and a Democrat on board from the beginning. So we are still looking for a Republican co-sponsor in the Senate. This bill would address all private and public insurance plans. So no matter what kind of insurance you have, it would address the issue for both children and adults. So, passing this would definitely, solve the problems that we have today in a big way. So there's a lot of, we've been trying, Katrina has been helping me a ton, so I really appreciate it. There are quite a few, we've been updating all our resources to help you advocate for the Medical Nutrition Equity Act and adding a lot of different things to the National PKU Alliance website. So I'm going to show you what we have out here. I'm going to switch over to the website. Okay, so if you go out here to our Take Action section, there's this overview information here, and if you select, or you can go directly and select Medical Nutrition Equity Act, what we've done is gone through and explained, what this bill does, what the status is, and asked you to take action in helping us find a co-sponsor. Down here, there's several guides to help you. So, what do you say when you call your representative? What do you say when you call your senator? It's always great if you can get in front of them, have a face-to-face meeting with your legislator or one of their staff members, because staff members are super, super important as well in terms of getting the message to your legislator. So there's scripts for you there. We're going to talk about this in a little while, some general tips on contacting Congress, something that Amy found for us through a friend, which is super great. So we'll talk about that in a little bit. We have the statement information about a resolution, very, very important. The American College of Medical Genetics and the American Medical Association work together, and the AMA has a resolution on the importance of covering medical foods. So this is a big thing because, members of Congress, they listen to what the American Medical Association says. And so this is a great document for you to take a look at, and it's a great tool for talking to your senators and House reps about how important this type of legislation is, and that it's very, very, very supported by the medical community. There's the statement from Genetic Metabolic Dietitians International. This is also a great description of why coverage of medical foods is so important. And when I say medical foods, I'm talking about both formula and the low-protein modified foods. So here's this is brand new here. We're trying to create a toolbox for everybody to use. So these documents in this section are things that you would want to share with your senators and representatives. This is the information flyer about the Medical Nutrition Equity Act. It gives an overview of the bill. This is our PK awareness resolution that Senator Isaacson and Senator Baldwin did for us this last year, and for the several, I think we've been having it for about 5-6 years. We've had a resolution, but in there it makes a very good case for medical foods, and it talks about, the fact that there's a lot of gaps out there today. So that's another thing to share. And then I would also share the actual resolution from the American Medical Association, because it does carry quite a bit of weight. And if you do talk to your legislators, either in person or maybe you're going to talk to their legislative assistant over the phone, send us an email and let us know how it's going, and we'll keep track of all those contacts that are made. Okay, so there's a lot of information out there that hopefully will help you, and we will just continue to build that sort of toolbox of advocacy. Okay, so let's talk a little bit about state mandates, because we get a lot of questions, from different people. What can I do in my state? Because we have 39 states that have some type of legislation. Some of them have age ceilings, right? So adults may not be covered, or they may just cover PKU. They don't cover other newborn screening conditions, or they don't cover low protein foods. And so there's definitely a lot of work that we can do at the state level. We also have to understand that if we have a state mandate, that only affects insurance plans that are regulated by the state, but it is an important thing to have. It is definitely positive to have a mandate in your state. So this is actually a brand new, this link here. If you click on it, it will take you to a really wonderful summary as of November 2016 of all the statutes and regulations around medical foods in the country. So you can take a look at that and see where your state is, what's their status, how are they doing, and see if you can, and if you're out there and you really want to get in there and work with your state assemblies to make a change and improve it, we would be all for that, and we'll certainly try to help you any way we can. I would say, you want to make sure that if you're going to tackle a mandate, that you want to build a very strong local advocacy team. I definitely believe that even one person can make a huge difference. I mean, one person can certainly get something done if they really put their mind to it. But it's helpful to have a team of people around you when you're trying, to help you. Particularly, it's important to talk to the clinic. Let them know what you're working on. If you have a newborn screening advisory committee in your state, even if you don't sit on that advisory committee, hooking up with them to talk to them about what it is that you want to accomplish, they can be great members of your advocacy team when you're looking at state mandates. And of course, any local PKU organization, hook up with them if you're not already connected. There's other really neat great things out there. So NOR, the National Organization of Rare Disorders, has a Rare Action Network. They had a wonderful webinar yesterday, which they talked about state mandates. And so there are other advocates in different rare diseases that are also trying to get their voices heard. And so you can team up with them and try to go out this together. So I would definitely look at NOR's Rare Action Network, see if you can get involved, RDLA, RDLA. There's just several different groups that you can work together to accomplish things. So sometimes there are some states where it's easier to pass a mandate than others. My state of Georgia is one where passing a mandate is very, very difficult, and if not impossible, the way that they feel about health mandates. And so there's another option that you can investigate in your state. So a state, state budget line item, perhaps setting up a fund so you can think about, okay, well, there's all these gaps in insurance, and is there something that the state, public health can help, help in some way to have an assistance fund?
I'm listening to a webinar. I just don't want to. I didn't want to be on speakerphone. I'm listening to a PKU thing. Well, I need to have both.
So we can. So this is a great option. Seeing if there's ways for your state to allocate funds to public health to assist people who don't have coverage don't have insurance or don't have insurance that covers their medical foods. There are several states that do this. Some states you don't go through insurance at all. The state just provides your formula. And then there are some states where there's a combination. So Kentucky would be a good example of a state that I hear there's some background noise. Can you mute your phone? If anybody has any, there's background noise, mute the phone. So Kentucky is a good state as an example. They have a pretty good mandate, but they also have money is raised through their birth certificates to create a fund to help people, and so then there's an application process. And so that's kind of neat because they kind of plug up all the holes, right? They have the best of both worlds. Right? They have a mandate that's pretty solid, and then they have an assistance program. And then, of course, I mentioned this before, but even if your state has a great mandate, and that only applies to state-regulated plans, and so having a safety net for people is a great idea. See if I can get to the next slide here. Okay, here we go. So I mentioned Georgia, and we talked about this at the National PK Alliance Conference. We had a breakout session, and we talked about Georgia a little bit. And so I wanted to just give you an example of, and some details around how you can solve, some gaps with a budget line item. So probably 6 years ago, I would say, 6, 7 years ago, we thought about, gosh, we really need a mandate in the state of Georgia. So a group of people, PKU and some other of the inherited metabolic disorders, a GI organization, we teamed up and proposed a mandate. We had an extremely strong sponsor. It was the majority whip in our state house. And so, I don't think we could have had somebody better trying to lead this for us in the Georgia General Assembly. We did end up getting a lot of pushback. I mean, we had to go through a lot of hearings in our House Insurance Committee, and our state was just not going to budge when it came to passing a mandate. They were completely 100% against it. So we really gave it, really a big, we tried for probably 3 years solid, and then we just realized, I don't think we're going anywhere. Let's see what other way we can address this issue. And so what we did is, we looked, we have every state has a statute around newborn screening, and so we took a look at that. Well, let's go back to basics here, and realize that we should, based on the way that our newborn screening statute was being presented, we really should be helping people with treatment here in Georgia. And so we pitched that to the House Insurance Chairman, who was the same person that would not budge on the mandate. And he surprisingly thought, okay, I kind of like this. Like, you're going to raise the newborn screening fee a little bit. And what that means is that it's not just the small businesses, right, through their state-regulated insurance having to pay an increase in premiums. Everybody, all insurance has to pay the newborn screening fee, right? So you're not just picking on one little part of the insurance market or the small businesses. So he actually was very positive as soon as we said it, which we were completely caught off guard and very excited about. But from that idea, it did take us a little more than 2 years to actually implement it. And so in the end, and I'll give you a little bit more detail, but July 2016, so this 2016 budget for Georgia, they allocated $1.2 million per year to providing assistance. So that was just huge. And we made sure through the process that it was going to be enough money that we could tell everybody in Georgia about this program and we would not have to turn anyone away. So it was a big, big success here in Georgia, and we're super excited about it. So just a couple of things why we were successful. We started out by collecting data from other states with medical foods assistance programs. So I think I reached out to Louisiana, North Carolina, Florida, and maybe one other. And so we looked at how much money they were spending, and the population that they were having to serve. So we looked at, did they have mandates? Are they just having to help people with small, state-regulated plans? And we bumped that up against population in Georgia to come up with a good estimate of how much money it would cost us each year, which told our state budget office, how much they would have to raise the fee and all of that. And so we didn't wait for them to kind of come up with the numbers. We just decided we're going to come up with the numbers on ourselves, and present it to them. And it worked out great that way, because if they have to do less work, they're more likely to say yes. And then we also, of course, hopefully looked like we knew what we were talking about. So there were several sort of points that when we went to talk to the House Insurance Chairman, particularly, that we kept driving home. One, our Georgia newborn screening statute does state that part of the system is initiating and continuing therapy. And what that says to me is that as a state, part of our responsibility is making sure people have medical foods. So we sort of drove that home, that we can't just say that we do that, we actually have to do it. And so I think that certainly helped. Also, we looked at what our fee in Georgia was compared to all the other states. And so the fees range from $0, which I still figure out how they do that, but $0 to I think $152 per year, and ours was $50. So we definitely had room to go up. So they weren't going to look at us and go, oh, we're raising this much higher than everybody else. So that was a positive for our argument in Georgia. Of course, not treating the newborn screening conditions results in disability and death, and that argument, they don't want to go anywhere near thinking that they are going to let that, some bad things happen. Those disability and death happen to their population. So that's, of course, a good argument. And also that we have too many maternal PKU syndrome cases in Georgia. It was fairly common, too common. Of course, we don't want any of them, we don't even want one case, but they were fairly high in Georgia based on the information that we were getting from the clinic. And of course, it's cost saving and the right thing to do. I would say we definitely had our ducks in a row in terms of the data, but what made it happen is that we were absolutely relentless. So this Georgia Assembly is about a 2.5 to 3 month session, and so January through March. So starting in August, we started going down there to the Capitol to meet with the insurance chairman, was basically the gatekeeper of this happening, and I think met with him every 2 or 3 weeks, and then yeah, so I would say, well, maybe it was July because he started coming. So every time he was at the Capitol, we were there. We were on the sort of the email list from his secretary, and every time he set foot in his office, we were right there. And we wanted to make sure he knew that we were not going to go away. And of course, we were always kind about it, but I think he understood from the beginning that we weren't going anywhere, and we were not going to take no for an answer. The other thing is, after the first year of advocacy, we were able to get a line item in the budget, and it was a learning process all through, it was always a learning process, but we realized that after the first year there was no money actually behind it, right? They didn't do the budget part. The other thing is here, where you see I have individuals underlined, the first year of this line item, it said children right there. And we had really said, we had said that adult coverage was, not having that was a deal breaker for us, but they sort of slid that children word in there. And then the next year we went back and made sure that it covered all adults too. So that we had to keep pressing that over and over and over and over. But in the end, it worked out. The other, and I alluded to this before, in terms of having an advocacy team, we worked with other advocates from other disorders. We were very, we updated our metabolic clinic often so that they knew what we were doing. We could reach out to them for help, for data if we needed it. We also talked to our public health officials. The newborn screening lab director, almost all that $50 that he was getting, he used, right, to do newborn screening, the laboratory work, and they needed extra money to do that because we were adding different disorders, right? So he needed money too. So I needed to make sure that he was bought into the fact that we were going to ask for an increase, right? Because he probably wanted an increase too. And he's a lovely person, and he believed in what we were trying to do, and so he supported us. So that, I think, was really, really, really important to make sure that everybody involved in newborn screening and caring for PKU patients knew what was happening. Okay, so that's Georgia, and we will see. We may think about trying to push for a mandate again, but we'll see what happens with that. So best practices, and these are things at the state level or at the federal level. Make sure you plan ahead. You focus on your goal. So always focus on the goal, right? We want medical foods covered. We're going to just keep working at it until we get it done. Coordinating with stakeholders and constituents, face-to-face meetings. It's great. But I would say in terms of the federal, your U.S. legislators, if you can develop a great relationship with their legislative director or their health legislative director over the phone, then that is great. That is a great, great thing. So don't feel like you have to, get to D.C. You can also meet with them in their local office sometimes, right? They're at home. Maybe they're on a Friday or on a Monday. They're going to stay local. And so maybe you can meet with them there. And clearly articulate the issue, manage sort of all the details. So a good detail example would be the, making sure the word individuals was there and not children. So all those little things in the end make a big difference. The other thing is, propose options, offer flexibility. So an example of this may be, we want, Senator Graham, we really want you to support the Medical Nutrition Equity Act. This is going to solve our problem. It's very important. We need you on board. But if you start to go, oh, no, ask if you know he's not going to do it, or even if you're not sure he's not going to do it, you might say, you know what, can you help us with Medicare? Can you call CMS? Can you get us a meeting? Can you, see if you can get them to fix, federal employee insurance? So there's always different, there's some ways, that we want to outline for solving the problem, but we always want to be open to other ideas that they may have, because getting back to focus on the goal, we want medical foods covered. So however we need to get there, let's get there. Be persuasive, tenacious, tactful, and charismatic. That's always good. And then I have a link to this tips on how to contact Congress. Now, Amy found this. Do you want to talk about it? I can go to the web page if you want. Let's see.
Sure, I'm happy to. I've just been madly typing answers to questions. So
oh, you are? Okay, great. Okay, great. Thank you. Let me get to the website here, and I'll click on it because you're more familiar with this than I am. Okay, general tips on how to contact Congress.
Okay, so this is a one-pager that was put together based on advice given by a woman named Emily Ellsworth, who worked for several representatives of Congress here in Utah, which is my home state, and so I became aware of it through some local channels. And it was kind of her best tips for how to make a difference in contacting your member of Congress. And what it really shows is that they really do listen, and that the staffers and the people who answer the phones are sometimes even better to talk to than the actual member of Congress. So don't ever be discouraged if you get a staffer or you can't make an appointment with your member of Congress, because the staffers are the legs of the office, and they're the ones who are going to be putting everything together. So you can, take the time to read through this, but a few key points are that you have to call them. You have to reach out to them. You have to make a personal contact with the office. Like she says, doing social media really isn't that effective with members of Congress unless it was, the entire nation doing something. So what you want to do is focus on calling the office, and you can call the Washington, D.C. office, or you can call the local office. So every member of Congress, every senator has a local office, and I have done that on numerous occasions where I have gone here in Salt Lake to the office of my members of Congress and talked to their local staff, and they will report back to the staff in Washington. And so it really, really does make a difference when you go meet with them in person. A quick story, when I went down to meet with Senator Lee's office here in Salt Lake, I took a can of Phenex 2 with me. It was empty, just so I could show them what I was talking about when I talked about formula. And I actually had them smell the empty can just to get an idea. And about a year and a half later, I went back on another meeting, and as soon as I pulled out the can, they knew exactly who I was and what I was talking about. They remembered my prior meeting with them, and it stuck in their head because of the can of Phenex. And so it's absolutely important that you reach out to them on a personal level. You can do it by phone, that's great too. Doing it in person, I think, is even better. So this is a great way to reinforce that you really can make a difference.
Absolutely. Thank you. Thank you, Amy.
Yes, anytime.
Right. And one of the most important things, right, don't take no for an answer and then say thank you, right? Those are probably the two most important things. Don't take no for an answer, and always say thank you. Okay, so Amy, I don't know if you want to talk about this, or I can mention, two things are changing, right? There's different things going on in healthcare, and so we're going to have to see how things play out with the Affordable Care Act. But making sure that our PKU voice is heard in terms of advocating for some key provisions that help our community. So, the fact that we no longer have lifetime limits, children can stay on their parents' insurance until age 26, no exclusions, no denials for pre-existing condition. The expansion of Medicaid has certainly helped people. So those 4 provisions are pretty important to PKU community, and so we want to make sure that our voice, together with the voice of other rare diseases, chronic diseases, is heard, and so that's going to be something important. But there's a lot of partner organizations that are doing the same thing. So it shouldn't take too much effort to do this in terms of what we need to put together, because it's fairly clear. We did put together a position statement the other day that is now online. I'll show it to you in a minute. That can be shared with congressmen and women about how the MPKU, what the MPKU would like going forward in terms of healthcare. And it's basically, protecting those important provisions and then addressing medical foods coverage. And so the other priority, work with Congress to resolve medical food coverage gaps in federal programs. So this is something that where I would say an example would be, and I know Shane the Ostermans, your family's meeting with, I think, Senator Grassley or Senator Grassley's office tomorrow. So certainly talking to him about supporting the Medical Nutrition Equity Act and being a Republican co-sponsor, right? That would be so wonderful, right? If he would do that. But you can also ask him, can he reach out to CMS? Can he help us address coverage for federal, the Federal Employee Health Insurance Program? Can he help us with Medicare? So those are things that he may be able to do, or he can do, is to try to influence those federal programs. So I would say that's going to be another priority for us, is what can we do, because you don't necessarily have to have law, right? In the case of the NDAA, legislation was able to influence TRICARE, but perhaps we don't always need Congress to pass a law to improve the coverage for federal programs. Assists with state-level efforts. So in Virginia, they're trying to get a mandate passed. North Dakota is trying to improve their mandate. And so, we want to assist in any way we can in making sure that, changes or new legislation is written in such a way that provides the highest level of coverage for medical foods. And of course, we want to continue to encourage members of Congress to support the Medical Nutrition Equity Act, but there's quite a few organizations. The gastroenterology organization that I mentioned before, they have a lobbyist, on Capitol Hill actively working on this issue. They did a lot with the National Defense Authorization Act in terms of, giving us examples of letters that we could send, and so hopefully, we can work together with quite a few organizations and continue to push that Medical Nutrition Equity Act. Is there anything, Amy or Christine, you want to add about the priorities? No. I think we're trying. I think the key, the thing here is there's a list of 4 big things, and they take a lot of work, right? Because there's a lot of documentation and messaging and, of course, effort on the ground that has to happen to continue pushing these things. And so, we got to do the best we can, and we're going to try to prioritize things to have the biggest impact, as we see what's going to happen with healthcare policy over the next several months. Okay. Amy, do you want to talk about this, lobby days in May?
Yes, sorry, getting off mute. So the National PKU Alliance, every year that we don't have the conference, has a board meeting that we do in person in Washington, D.C. And so our board meeting this year is going to be on May 22nd. And what we do is, in connection with that board meeting, is we schedule lobby days where we as a board, but also as members of the PKU community, anyone who wants to join in, can meet with us and do some lobbying on the Hill. So we would love to have people join us. We've had people from all over the country come. It's a really fun experience to walk on the Hill and see our country in action in person. But even if you can't come to DC, what you can do is you can set up a meeting for us and we will go for you. So for instance, if you are from Idaho and you call your senator's office and say, I'd like to set up a meeting to talk to the senator's staff about this issue, and I can't make it by myself, but I'm going to have the National PKU Alliance attend on my behalf, and they will schedule the meeting for you. So Kristen and I and others find ourselves, going from meeting to meeting and meeting with people from all over the country, and so you don't have to come to be able to help us. We would love to have the problem of having too many meetings that we would have to run all day. That would be our dream. So everybody can help us set up a meeting. And we've had a lot of fun doing it, and we've made a lot of progress. We've educated a lot of members of Congress, and this year, we're going to have some new members of Congress, and so again, we'll have an opportunity to educate them on PKU and the needs of our community. So we have on our website, I think, Kristen, it's still there, instructions on how to set up a meeting and how to request a meeting. And it's never too early to ask. You could call tomorrow. Some of the offices have an online form to fill out, and they can refer you to that if you call. But it's never too early to set up an appointment. And like I said, on those 2 days, the afternoon of May 22nd and then May 23rd, we will have people in DC that can go to that meeting. So even if it's not you, we can do it. There we go. Kristen's found our fact sheet on how to schedule a meeting.
Yes, and so this talks about in-district meetings, but it's really the same thing if in-person meeting in DC. Yep. It's super easy, right, Amy? It's very easy. And I hope, I mean, lobbying at the Capitol is a really amazing, great experience. And I think if you're able to get there, it will just really, I don't know, really spark your passion for getting out there and trying to solve this problem. And then when you're back home and you want to call the DC office, you kind of have a picture in your mind, right, of who you're calling and what the offices look like. So it's a great experience. And we definitely want to have that problem of having to run from office to office. We want our feet to hurt when we're done after 2 days. Okay, let's see. Okay, so the biggest message here, you can do it, right? We all can make a huge difference, individually and together. So I'm excited that we have 25 attendees on the call. That's great. That's great. Okay, and so here we're going to have this presentation up online, so you'll be able to find our email addresses if you don't have them. But please, we're going to answer a bunch of questions for the rest of the duration of the call. But if you think of anything or you start, your advocacy work and you have questions, please email us. You're welcome to call me anytime. You can send me a quick text if you want. If you have a quick question, we want to make sure that we answer your questions and we help you. So let's see. That's the end of our presentation, and we do have quite a few questions here. So let me go through. Amy, I know you were trying to answer some, but let me go through from the top.
Yeah, Kristen, I think I've answered most all of them, although the very first one about an updated draft of the Medical Nutrition Equity Act,
right.
I don't know if we have any information on that, so I'll let you answer that question.
Right, so we don't have an updated draft yet. Senator Casey's office has been extremely busy with everything going on in DC right now, and so we were supposed to have a meeting the end of January, but my guess it's going to be a couple more weeks, but we'll try to get with them and see where we are with any updates to that legislation. And the updates that Shane is and Jackie you're referring to is we made some suggestions to modify, a couple of so the description of what low protein modified foods are. We wanted to align that. We got some advice from Ronnie Singh at Emory. Of course, she's been working on this issue for many, many years and is very plugged into sort of all the terminology. And so we would like to adjust a definition that's in the Medical Nutrition Equity Act for the low protein foods. We want to add dietary supplements, and the purpose of that is not necessarily for PKU, but for the other conditions. Sometimes they need an individual amino acid, so we want to just add that in so instead of it just saying vitamins. We want to add that, and we also just want to add the word medical food. So the way the legislation is written right now, it's medically necessary foods, which is fine because they are medical foods or medically necessary foods, but because the term medical foods is defined in the Orphan Drug Act, and it's mentioned in all kinds of health plans on the FDA website, we want to just put that term in there as an example of what a medically necessary food is. And so they're minor little changes, and so that's what that the updates question is in reference to. What I would say in terms of meeting with Senator Grassley is that what is in the National Defense Authorization Act, which I can send to you, is probably going to be pretty close. It's pretty close to what's final, what would be final. So that's sort of where we are with that. But we definitely want to, you know, get it updated. And but for now, I think the general idea of the legislation is not going to change. What time is that meeting tomorrow? Jean or Jim? Might be on mute. Okay. Shane and family, you can email me if you want to talk more about it. I'd be happy to this evening or in the morning. And thank you so much for making the scheduling meeting with Senator Grassley. Okay, let's see. Go down. Okay, Nicole, Amy, did you answer Nicole's question about the terminology?
I did, but I think it's probably helpful to go over it a little bit. And I will say, you know, the term is medical foods, and I think that's part of the reason I take with me the can of Phenex2 with me, so I can really explain to them what it is, right? So medical foods is something nobody's really familiar with in the general population, and I certainly didn't know about it before PKU. We also encourage people to bring with them any kind of the low protein foods so they can give the staffers they meet with a reference point. So typically we'll take like an empty box of the pasta, right? And we'll say, okay, so here's the formula. Here's what it looks like. You know, we mix it and make it into a drink. And here's how much it costs. You know, this one can cost $78. And this can is going to last, you know, 2 days or 3 days to give them an idea. And then we take the box of the low protein food and we say, you know, this is a box of spaghetti, but it's a specially made spaghetti and it costs $13 for one box. You know, when you can go to the grocery store and you can buy a box of pasta for $1, right? We have to order it and it has to be shipped and it costs $13. And so, you know, we try and give them a real world example of what the medical foods are and why they should be covered. We get a lot of questions about gluten-free and sugar-free, and, you know, none of that is considered in any of this. We always are very clear to say this only applies for conditions screened through newborn screening. It's a very small group. These are very rare disorders. You know, this isn't somebody buying the gluten-free at the grocery store. So we're always very clear that it's a limited population and it's a limited type of product because obviously it would be a huge concern if it covered everything like that. And we're very clear to say, look, we can't buy any of this at the grocery store, right? It's just not available.
Right, definitely.
This is Nicole. Can I jump in?
Oh, sure. Go ahead.
Okay. So yeah, that was all. That was a good description. But so Crohn's and the food allergies, those are not in newborn screening, as far as I know. And then, so you're saying in the Orphan Drug Act has the medical foods.
Right. So the Orphan Drug Act defines medical foods. So that's been around a long time. And when they put medical foods in the Orphan Drug Act, they were talking about PKU formulas. I mean, that originally, that's what they were talking about, right? And then medical, and if you look at the way FDA kind of views what medical foods are in terms of the definition that's in the Orphan Drug Act, they really keep the medical foods to mean those those types of products, formulas, and it could be also the low protein modified foods in some way are considered medical foods, to those things that are inherited metabolic disorders. So the things that we typically think of as metabolic disorders diagnosed through newborn screening. So inborn errors of metabolism. And they, like FDA has some guidance on what medical foods, you know, is, and they really keep it to those the inherited metabolic disorders. They don't seem to think that that's the medically necessary foods, formula type products that would be used for Crohn's. So there's some, so that's another reason why in the Medical Nutrition Equity Act and in the language of the National Defense Authorization Act, we say medically necessary foods and not the medical foods term specifically, because that legislation is trying to capture a broader group of diseases. Does that make sense? It is. It's so tricky.
Not so clear. Yeah,
Okay.
and I just want us to be comfortable. I want us to explain it well. You know, I want to
Right.
get in there. I want us to understand it thoroughly so that the person we're trying to convince, we can convince them.
I think what you can
Right.
say, Nicole, too, is that you can explain it for PKU and the related disorders to PKU. And then for the GI-related disorders, I think that the thing that's key there is it only covers those that are specified by name in the bill. Right? So it's very specific. It's not just an endless possibility, right? It has a very specific list of what would be covered.
Yeah, but we say right on here, Crohn's is like close to 800,000 people.
Right, but think how many people are in the United States. Right, that's actually a small number.
And they may
right?
not
It's huge
need it.
compared to PKU, right? But considering all the people in the United States, like compared to something like diabetes, that's a tiny number.
The other thing about the GI conditions is, from my understanding, when we work at the Georgia level with the AtVet organization, is that typically those conditions only need the formula type products for a short amount of time. Like while they're trying to figure out how to stabilize somebody, they're not typically long-term treatments, is my understanding. You know, the same way that PKU, you have to use them for life. And so the financial, you know, impact is not as much.
Right. So is that will be in the bill then? Like short-term treatment as specified
It doesn't
by
say
a
anything,
doctor's prescription.
right? It doesn't say anything about the length of the treatment. It doesn't say. It is hard because it's sort of a slippery slope because, you know, like I said, FDA, when they think about it, the term medical foods, they really are talking about PKU and allied disorders to PKU, because there can be this slippery slope. But yeah, it's tricky. It's tricky. It's kind of like,
you know, I would just say, this is Christine. I would just say, you know, speak from your own experience and speak from it as, you know, a parent of a child with PKU. And if they have specific questions about medical foods in the GI condition, you know, just find out what those questions are and tell them that you'll get back to them. And then we can, you know, we can volley those questions over to NASPGHAN or to one of the other coalition partners working with the GI conditions. You know, that way we are making sure that you're giving back accurate information.
Yep, that's a great point.
Yeah, I just want us to be ready when we have our meetings and they glaze. When you say food, they glaze over. So we need, so I can say, oh well, yes, food, but this is what it is. And Crohn's disease, not 800,000 people. It's going to be maybe whatever. You know, where can we get that information?
Yeah, so
go ahead. Sorry, Amy.
Sorry, Kristen. I was going to say, you know, you can never prepare for every question. And if they ask a question that you don't know the answer to, even if it's about PKU, the response Christine gave is right on. You just say, you know, that's a great question. I'm going to write it down, and I will find out an answer and get back to you. And to your second point, Nicole, you know, I don't find that their eyes glaze over when we have props. Right? And one of the best meetings I ever went to, and this is for the Iowa team, was with Senator Grassley's office. We had a young boy, Joshua from Iowa, who came to meet with Senator Grassley's staff, and he said to the staff member, where's your favorite restaurant, and what do you eat at that restaurant? And of course it was a steak restaurant. And so Joshua, who was I think 12 or so, said, do you know what I can eat at a restaurant like that? He said, I can have the vegetables on the side. He said, I can't eat any other food at that restaurant. And that really made a huge impact on that staffer because they've never thought about it like that. And so, like I say, using props and bringing it home with personal experience, like Christine said, really is critical in helping them understand PKU and the dietary treatment.
Yeah, but we're not looking for like empathy. We want a bill. You know?
Now, the empathy is where you start, right? If they like you, they're going to do more work for you, right? If they find you have an empathetic situation,
yeah, but
they're going to be more inclined to help.
right now. I mean, you're preaching to the choir. I get that, but it's just good to really know our facts when we go in there, you know. And if we can't answer something, of course, absolutely, we'll get back to you and follow up. But I was just wondering about the numbers.
Yeah, it's hard to have the numbers for the other conditions because I worked kind of trying to figure that out with the AppFed organization that deals with the acidophilic disorders, right? We worked with them when we were doing the mandate, and because the incidence rate of those conditions can be fairly high, some of them, it was hard to get our arms around, you know, what would the cost be, because they didn't necessarily use them for any, you know, they were like I said, short-term treatment. Yeah. So I would just refer them, you know, any questions like that. Like I said, you know, what Christine said, you know, we'll try to get the answer back, or say, you know, NAFTAGAN would probably have that answer for you, or something like to that effect. I for sure the props. I mean, when we talk about medical foods, yeah, it's a tricky term. I tend to focus on the formula, like medical foods. I'll look at this formula, this is how much it costs. My child has to, 80% of their whole diet is this formula. They have to drink it for life. And then, you know, small mention of the modified low protein foods. Not that they're not important, but if you focus on that formula, that's usually a fairly good tactic. And of course, that's, you know, the majority of the cost.
Right, right.
It is hard. I mean, there's no doubt. The terminology is tricky.
Well, I don't mind it being difficult. I just want to be as educated as I can having the conversation. That's all.
Yeah. You know what? The FDA guidance for industry on medical foods might really help you and others. Sort of, that might give you some answers in terms of how you might talk about medical foods. So I can send that to you. Maybe
but we're not talking about the FDA medical foods, or we are. I thought that someone said that we were not using medical foods. We're going to use medically necessary foods because we're not talking about the FDA foods.
Yeah, we are talking about that. Sorry. So when we talk about PKU treatment, we should use the term medical foods. We should use the term medical foods, and that's the same thing, you know, that FDA, you know, that's in the FDA special dietary foods category, and it's in the Orphan Drug Act, and the FDA has some guidance around medical foods. So yes, when we talk about PKU, that's really the term we should be using. It's just that the actual legislation gives a medically necessary foods. It uses that term as sort of an overarching description. But I wouldn't worry so much about using the, you know, saying medically necessary foods. I would just focus on saying medical foods. Amy and Christine, I mean, what do you think about that? Because I don't think we necessarily have to go into meetings and talk for the other conditions that are beyond.
Yeah, but we're trying to pass the bill, and that's part of the bill.
It is. But I think, you know, we go in there.
I would just limit it to the fact sheet that we have on the Act, which gives some background about the GI conditions, and just talk from your own personal experience, because that's what the legislators want to hear. And you know, since our personal experience is around PKU, that's where you should focus your efforts. And if they have specific questions about how the other conditions are managed, then again, I would just ask that you write down those questions, and then we can get the most accurate answer for them. You know, it's my understanding that the GI community does still use the term medical foods, and the reason why, you know, medical foods and why Kristen was actually referencing the Orphan Drug Act was because until the Orphan Drug Act came into being, I think in like 1983, at that point, all medical foods, whether it was used to treat GI conditions or PKU or other inborn errors of metabolism, were actually classified as drugs. And so that's what the difference was with the Orphan Drug Act.
Right, yeah.
But it's my understanding, it's my limited understanding that really, you know, and I don't know if we have any dietitians on the phone that can help, that, you know, also manage perhaps some GI conditions, but, you know, the GI conditions primarily are still treated by medical foods, but they're not treated by medical foods for life. They're oftentimes used in children or until they get stabilized. But again, I think if you just focus on your own personal experience, that's what's going to be the most powerful story.
Yeah. No, I think that sounds good because there are advocates for the other conditions that are also meeting with legislators, and so hopefully, you know, they're speaking to their conditions, and so you hopefully shouldn't have to give too much information about them. Okay, hopefully that helps. I was going through, Amy was doing a great job of answering all these questions. Let's see. If there's anything else out there. That would be federal. Okay, Amy. Okay, somebody asked, is it a federal law, right? So medical insurance, it would be federal level, so yes, states, if we can pass at federal level, states would have to comply. That's really the only way to address the ERISA-based self-insured plans is to have federal legislation. So, you know, even if we have amazing mandates in every state, that still does not touch the self-insured plans, which, you know, I don't know, what is it, 50, 60% of the country has that type of insurance, I think. I hope I'm giving the right percentage, but a very high percentage of people have self-insured plans. Okay, I'm just going through the questions. Susan, thanks. Okay. Does anybody have any questions that weren't answered on the chat, or any additional questions?
Hi, Kristen. Can you hear me?
Yes.
Sorry, I had to run out of the room for just a minute, so you guys might have touched on this. I just had a question about, do you know how the bill, and I don't know if that's addressed yet, how it would affect like DME companies? For example, I'm in Missouri, and we have Medicaid for my daughter, and we were using Option Care for well over a year, and then Option Care stopped covering PKU, so we were kind of, luckily our rep gave us a heads up, so we did like a mass order before we lost coverage, but there was not another DME company in the state of Missouri that would cover low-protein foods. So over several months, we've kind of worked directly with Canebrook and finally got our insurance to agree to bill them directly, so we wouldn't have to pay out of pocket. But I was just wondering if the bill addresses that at all, or what happens with DME companies. Do they have to, how is that regulated with them, I guess?
It doesn't talk about, you know, how DME specifically, but Raynette, I know you're on the phone, I think. There are, I believe, ways to address coverage if there's not a DME that in your state, I guess, that is covering it. Raynette, are you there?
Yes, I'm here. I'm sorry, can you repeat the question? If there's a DME that can cover in your state, is that what you're asking?
Yeah, so I was just curious if the bill at all addressed DME companies, because we had Option Care, and then they stopped servicing PKU, and they were the only DME company that we could find in our state that covered low-protein foods. I had no problem with formula, but the foods, we were really struggling, and so we've now got where Canebrook will just bill our Medicaid insurance directly, and I was just wondering if that issue at all addressed, or if that's really just a state-by-state thing.
Okay, are you just talking about the low-protein foods or the formula?
The low-protein foods. Formula.
Okay. Okay. For low-protein foods, it only takes an extra step to get things covered, and it depends on the DME company that will be billing your insurance company direct. So when it comes to Medicaid, usually Medicaid will not cover any DMEs that are out of state. It has to be within their state of that Medicaid. So some DME companies apply as an out-of-state provider. So they can be a provider, but an out-of-state provider in which they can bill for this particular state Medicaid for low-protein foods if this Medicaid plan covers low-protein foods. And another is if you don't have Medicaid, then and someone has an HMO plan and just has in-network services, then there's options of gap exceptions where that you can't find a low-protein food provider within a 100-mile radius from your house. So they have to give or honor a gap exception for, let's say, Cambrook to provide these low-protein foods. That's something I'd like to focus on this year. My goal is to focus on the coverage for low-protein foods and to help everyone understand or how to work around getting this covered, because there's a lot of patients out there going to the grocery store, looking at ingredients, there's temptation going on, and still paying a premium for their insurance and not knowing that this could be covered. We have an S code, a medical description code, that specifically says solid low protein modified foods. Why not use that? Why not work around that? Don't take no for an answer. So those are the things that you would have to look for a DME that could bill a Medicaid as an out-of-state provider. And then I do have a small list of low protein food providers, not too many, that do bill certain insurance companies and orders for you the low protein food products. I can share that as well.
Okay, great. Yeah, thank you. I mean, we ended up kind of doing the thing with Cambrook where they're just now direct billing was the only option we had because they weren't allowing us to accept out-of-state providers.
Right.
To bill directly. So we figured that part out. I guess I was just wondering if new legislation, it affects all the insurance companies, but do the DME companies have any responsibility as far as having to adhere to any of those, you know, like, so if an insurance company can't say we can't deny you PKU coverage, is it DME companies still can say we don't want to cover PKU treatments or products?
That's the company decision or policies that they have within that company. So it's made only within house, okay. Whether or not they want to oblige by that. But when it comes to insurance plans, they must oblige by any state mandate.
Okay, all right.
Mm-hmm.
Thank you.
I hope I answered your question.
Yeah.
I love all the conversation on the chat. It's wonderful. All this back and forth, answering questions. Great. Does anybody have any question there that you may have put on there that we didn't answer? Joe. Okay, Amy's doing a good job of answering the questions. Sorry, I'm just going through everybody to make sure. Okay.
Could we just clarify the time for lobbying again? Because someone said 2 days.
Oh, in DC?
In DC, yeah, I'm sorry, in DC.
Right. So usually there's a board meeting in the morning, so that will be May 22nd, and then that right after that, so for the afternoon we would spend on the Hill, and then the following day on the Hill.
22nd,
so
23rd then.
22nd and 23rd. And of course, if you want to stay longer, you can too, right? You can stay the whole week.
The hotel is so expensive.
It is so expensive, but in a day and a half, we can get really a lot done. I think one year we had 60 meetings or something. It was great. It was great. So a lot can be accomplished in a day and a half.
Do we know what time the board meeting is, the 22nd?
Amy, do you know?
So we can schedule meetings after that?
Yeah, we usually ask
meet in the
people not to
morning.
schedule. Yeah, we ask people not to schedule any meetings before noon,
okay.
so that we can have our meeting in the morning, and then we have a group meeting with everyone who's there to advocate, and we all go together over to the Hill. You know, typically we might have one meeting earlier than that, and someone will run and cover it. But ideally, we try and not have any before noon, so we can all go over together, and then we can do our board work in the morning. And just so you know, we will be getting a group rate at a hotel in DC. So if you are traveling out there and interested in that, you can let one of us know, and we can keep you in the loop on that.
Oh, great. Do you know which hotel?
I don't yet.
Guessing a Hilton.
We stayed at a little hotel
like
that was
Hilton.
nice one year, right in Washington Circle or something. I don't know. Sometimes we've been to small little hotels, which are nice too.
Mm.
Yeah, we've sort of just been wherever the best option is, so we'll see what that is this year.
Right.
Okay, great.
And close to a subway, or not subway, but the
Metro.
the metro there in DC is always great too. And these meetings usually last, your meeting would last maybe 15 minutes. So it's very common to, you try to, if you can try to organize your meetings maybe for your state, all the different reps, even just 30 minutes apart sometimes you can get from place to place. So it can be a busy but fun day, fun experience. Okay, does anybody have any other questions? No? Okay. Well, we will wrap up. Our email addresses are here. Again, please, please, please feel free to reach out to us anytime, and we will do our very best to help you. Okay? Thank you all, and this presentation is on, and I didn't show you all where it is, but if you go to the Take Action page on the National PK Alliance website, the presentation and the recording is going to be in the bottom left of the page. Okay. All right. Well, thanks everyone. We look forward to having another webinar.
The recording will be up in the next couple days, but the actual slideshow is up now.
Awesome. Thank you, Katrina. Okay, thanks everyone.
Thank you, everyone.
Have a good night.